Welcome to the Perspectives on Health podcast. Today we have Dr. Michael Gould. He is a busy has a busy GI hepatology practice in Vaughan and is a staff gastroenterologist at the Etobicoke Campus of the William Osler Health System. He is the president and medical director of the Vaughn Endoscopy Clinic, a clinic located north of Toronto in Ontario. He is the president and partner in TDDA Specialty Research, which has participated in many GI clinical research trials and all aspects of gastroenterology and hepatology. He is a principal investigator on a number of trials and a sub-investigator on many others. He is the past chief of medicine of the William Osler Health System. He is the past president and one of the founders of the Ontario Association of Gastroenterology and currently sits on the OAG Board of Directors. He was the Cancer Care Ontario endoscopy lead from 2011 to 2014 and helped design the endoscopy quality-based procedures program. He is currently the endoscopy director at William Osler Health System. He has been a member of numerous colon screening, guideline, and quality committees at both a provincial and national level. He is a faculty member for the Canadian Association of Gastroenterology Skills Enhancement in Endoscopy program and is a recognized leader in endoscopy quality. He is the co-chair of the OAG Post-Digestive Disease Week educational meeting, which occurs annually, and we're really excited to have him on the podcast today. Welcome, Dr. Gould.
Thank you. Thank you.
So tell me, what has life been like for you during COVID-19?
Well, it's been an interesting time for me since on March 15th, I came back from Vail, Colorado, probably the hot spot in the United States at the time for COVID. Came back to worked for 3 days when everything was shut down suddenly. So I went and was told I had to go into isolation, which I did up in my chalet in Collingwood, which was awesome, only to get a fever on the Sunday. Had my swab that day. Felt really, didn't feel great, but I didn't feel bad. I had fever for 3 or 4 days. And about day 8, I found out I was positive for COVID the day after.
Wow.
I'd been back on a bike and out for a ride.
Wow.
So for me, well, I had COVID and I know where and who I got it from. It was a flu, and that's what it was. And I couldn't go back to work until I had 2 negatives. So I had my head drilled 6 times in total. For anybody that wants to know about the experience, It was tolerable at best. Not much, not really tolerable, but it did make do. And then I went back to work to really a non-existent medical care delivery system. Everything was shut down because of COVID. Everybody was afraid of what was going to be. And now 3 months later, which we are, I think, what's today, the 22nd, so 23rd, yesterday was 3 months since I found out of my positive test. We're just sort of starting to get back. We went from basically I would do 1 or 2 endoscopies a week, and I'd have a phone office every day, which I had all through my COVID time too. I would make my phone calls. And just slowly, this week, we're back into our phase 1 where we have a block a week with a little extension. So, I'm still down in practice probably to 40% of my practice. That's it. So people have been waiting for months. We're trying to get in all the urgents and people that are really symptomatic. We've canceled 3 months of patients. Fortunately, people haven't wanted to come and don't go to their family docs. So the referrals have slowed down, fortunately, in a way, because we can't tell anybody when they're going to get scoped for anything elective, which is really unfortunate because down the road, the consequences of not doing many of these things may unfortunately come back to haunt us.
Right. Well, I don't think anybody who went into medicine as a career would have anticipated going through something as dramatic as the COVID-19 pandemic. When you started out, why did you choose medicine and then GI as a specialty?
They've been asked that question my whole career and never really had a good answer for it, even before I got into medicine. I have always wanted to be a doctor from whenever I remember high school back, whether it had to do with my dad dying when I was young or who knows. I always wanted to be a doctor. did medicine. Went to McMaster undergrad, did medicine, did internal medicine, and then did GI. I mean, GI for me has always been a really good uh, combination between academic medicine, sort of the internal medicine approach, and and procedures. You know, there was part of me that wanted to be a surgeon, but this for me has been really a very rewarding approach. So I do, you know, all kinds of procedures. I did ERCP. I've done all aspects of colonoscopy and gastroscopy, and it allows me to think about nutrition, liver disease, pancreatic disease, GI disease, as well as do procedures. So for me, it's been a really nice mix of what I would have wanted out of a career. And it's been a very rewarding career, both clinically and, as it turns out, both administratively and academically. You know, I started off in academic medicine and went to do more administrative medicine. When I was young, I was chief of medicine for a long time. I would never have known that this is where my career would have taken me, but it's been a pretty rewarding career overall.
And you've also branched out to be somewhat of an entrepreneur and done opened some of your own private businesses as well. What led you to do that?
You know, for me, it's always, I actually am a very entrepreneurial guy, and I'm always looking for business opportunities. And for part of them are just extensions of what you do, you know, doing the research thing, which we've been doing for 20 years. And now we're just expanding. We've taken on a partner and we're expanding it across the country. It just grew from something we want to do. We want to look after GI in the western part of the city. So a bunch of us got together. I would say if I ever had a strength, it's somehow getting all these guys to sort of work together from multiple hospitals, multiple approaches. That's whether it was the OAG, whether it's TDDA, whether it's the Vaughn Endoscopy Center. For some reason, I've been able to herd the cats, you know, as they say, and get people, for the most part, working together to build things. And so the research company grew and led to us wanting to do endoscopy outside the hospital, partly for the research perspective, partly because when we started this, 12 years ago or 13 years ago, we all had 9-10 month year waiting lists with nowhere in sight. The hospitals weren't increasing endoscopy time. And we all decided to look after patients. We had to do this. We always thought that the government would step up to the plate and help us fund this, which they never did. And that's always been a disappointment. My biggest disappointment when I did the CCO stuff. But nevertheless, we're here and providing, you know, in the clinics, we provide 160,000 colonoscopies a year for the province. But if that didn't exist, I don't know what we would do, plus the gastroscopy. So it's over 200,000 procedures done by the docs, paid for by the docs on behalf of the patients of this province, that really is given no mind. They just say, thank you, what are you doing for me next kind of approach. Anyways.
So, you know, that's an interesting point that, you know, obviously they've developed into a critical part of the healthcare system, these private clinics, you know, obviously in a public healthcare system. What do you think has led to that gap in understanding from the government of the role that private clinics play?
You know, I don't know that there's a gap in understanding. I think that's the, I think they understand. We've been, in terms of many capacities, have made multiple submissions to the government about the benefit of these clinics. And, you know, listen, we started the college's assessment program and developed a quality framework and rules for clinics that clinics have to abide to. So again, we did that probably 7-8 years ago when we started that. And now there's a whole OHP system that's accredited, monitored, you know, accountable, and there's always things that you have to follow, much more stringent than the in-hospital rules, actually. So we started that. I can't remember when I was on that committee and did that a long time ago, and that's just started. So we've built a very strong program. The government knows we've built a strong program. And when I was at CCO, we had made a whole proposal and had them, in fact, switch from OHPs to IHFs, independent health facilities, and with the goal of getting them accredited and funded. And, we had it all ready to, that's what I was doing partly when I was the endoscopy lead. And it was supposed to be implemented April 1st of 2014. And on March 31st of 2014, they said, no, we're not going to do this, after building the whole program with most of the facilities going out, paying consultants to make sure they met all the criteria that they needed to for IHFs, and the government pulled the plug. And to this day, most have still stayed. Some have gone out of business because the business model is very difficult and very challenging, only to come around where now it's probably more important than ever to have these outpatient clinics, because we're going to start, and most of them have started opening back up, where hospitals are still at 30% capacity. And to make up 3-4 months of backlog, the hospitals are going to have to go to 130% of capacity, which they won't be able to do because of potential funding issues, which isn't true, because they haven't been doing any of the cases which they've been funded for, so they still got to do them. But more importantly, staffing. Like, you just can't get, you want to open up another room, which we fortunately have, you need 3 or 4 more staff. Well, you just can't get them overnight. They're not available. We don't even have our existing staff because they've been redeployed. So we have to get back existing staff. Then we would have to hire staff. So we're hoping, in fact, to even have an opportunity of using these clinics, if for nothing else, in the transition time, to try and help deal with the backlog, because they're all awesome, excellent programs, excellent facilities that are all, monitored and approved by the government, and should be used to help us get out of this hole that we've unfortunately found ourselves in because of COVID. Long-winded answer.
No, great answer. Now, the Canadian Association of Gastroenterology put out a statement on doing procedures during COVID, and I know that you were recently involved in developing a position statement, if you will, for clinics to reopen with the Ontario Association of Gastroenterology and also the OACE. Could you tell me a little more about that? And now that these clinics are going to play a critical role in the catch-up, if you will, of all these elective cases, what type of precautions should they be considering?
There's been this whole dialogue between IPAC, which is sort of the provincial infection control group, and all the GI groups, AGA, OAG, CAG, every European GI group, about what kind of procedure, for sure, gastroscopies are, let alone colonoscopies, in terms of, are they high-risk procedures or not? And there's no agreement between our infection control people and all of the organizations that tell us how we should do it. So for the most part, all the GI organizations have said these are high-risk procedures, and our IPAC says they're not AGMP, aerosolizing procedures, so that we don't have to be quite as worried about them. So because of this difficulty, and this difficulty was experienced at every hospital around the province in terms of discussions about PPE with their local infection control people, we've all went about how are we going to do this safely. So when the government asked everybody to back off elective procedures back in March, everybody closed I shouldn't say that. I think the majority of people closed down their outpatient endoscopy facilities. I don't know for a fact that everybody did, but most did. And we weren't doing anything. So we all had rent. We still had staff, which we had, some were laid off. We had all the issues of every small business in the province. We were generating zero income because we were not doing any procedures.
Right.
Only now are we figuring out whether we're even getting that rent relief from the government, which I think we're finally going to get, but that's 3 months into it already. So big issues for all of us. Nevertheless, we decided at some point we were going to have to start up. As things started quieting down, we felt it was safe to do so. And so we, as a group, every group was sort of looking at it separately. We took sort of the one we had been working, and we decided to provincialize it. I don't know if that's a word, but make it so that it was it was
It
the
is
same.
now.
It is now the same approach for all of us, right? So that one, there's safety in numbers. Two, we get a bunch of people who all are interested in quality medicine and making all the rules that will protect our patients, protect our staff, protect us, and just make sure we do this safely. And it's rejigged everything we did. So we went about from the second you talk to people, how you consent people, how you bring people into your facility, how many people you have in your facility, how you recover them, and how you keep them, so how you distance them and flow. And so it was reduced flow. We all only decided to do colonoscopy in the first,
So no gastros at all, right?
no gastros at all.
Okay.
I just got some weird thing I can't see on my computer. I apologize. Hope it doesn't cut out. And so no gastros, we all decided, and how we were going to produce, we're going to flow colonoscopies. And that's pretty much what every facility did. I think everyone's up and running now in some capacity. We had reduced days, reduced numbers, but we're sort of building up. And now we're in the midst of moving on to our phase 2, where we're going to start doing more procedures, because we've done whatever we said, and we were only limiting it to symptomatic people. So we weren't doing average risk screening. We weren't doing your 5-year surveillance and all those things. And so we have now had another meeting where we're probably, as of July 6th, so the week after the long weekend, people will start moving back towards normal. I think it's been a month since the government said we should start thinking about this. And the clinics for sure have cleared out, I'm sure, most of their symptomatic patients, since the majority of patients coming to clinics still are routine screening, surveillance, and some mild symptomatology.
One of the things I noticed in reading the statement was there was still quite a concern about availability of PPE and kind of conserving it, and that the lower patient flow, could partly be attributed to that as well. Is that still an issue?
It depends what you want, but I think everybody. So the OAG, we took it upon ourselves to try and secure PPE for whatever clinics wanted. We joined with the Ontario Associated Clinical Endoscopy group, and the two groups did both the guidelines and the PPE acquisition together.
Okay.
And so we secured a way to get masks, and face shields, N95s if people wanted or could get them. They were harder. And then we also got gowns, and the OAG procured almost 2,000 gowns for people that then purchased for themselves. So we took it upon ourselves to make sure as an organization we got people who wanted PPE, they could have it. People could do it on their own for sure, but at least we secured that. And I think everybody's got the PPE they need for gastros. And then a discussion about N95 masks come back, and that'll be, I think, not as consistently applied across the board as what the first wave was.
Well, there would be concerns also about just the aerosol nature as well in the rooms, would there not be?
Again, there is. That, I would say, if you use an anesthetist, and most of the clinics use anesthetists for various reasons, that may not be part of today's podcast, could be another one. There's less coughing and stuff when people are having gastros under propofol. When people are having gastros under fentanyl and Versed and xylocaine spray in itself is aerosolizing, and when they're not sleeping, they're coughing, gagging more, and makes it much more potentially aerosolizing than not. So the question always is a face shield and a good surgical mask appropriate, or do you need N95s or KN95s? Do they need to be fitted? Do they not need to be fitted? There's this debate. The fact is the risk is probably really low regardless of what you do. There's been now having how many millions of people with COVID around the world, and lots of gastros being done. I don't think it's ever been reported that someone's got COVID from doing a gastroscopy under any circumstances that
Okay.
I'm aware of, that I've seen reported. I'm always looking for that kind of stuff. So
Hmm.
as much as the CAG and AGA and, American GI groups have all said we need to do N95, HEPA filters, look at airflow and work. I think
Hmm.
that's not really practical, and it's probably overkill. And there's no way for most facilities to change their airflow, whether it's an
Hmm.
outpatient or even a hospital. I mean, if you don't have negative pressure and you're not in those places, you're not, rebuilding rooms just post COVID. It's nice for people to say that, but I'm not sure it's very helpful or effective.
And another big thing in the statement was the pre-screening aspect and how important that was going to be to make sure that high-risk patients weren't coming into the workflow.
Well, for sure, everybody has to own up to whether they're sick or not. And if you're sick, don't come. I mean,
Right.
I think that's going to be across the board as we open up life. You can't. In the old days, you just sucked it up. You went to work when you were sick. That has to be an approach in life across the board that doesn't occur anymore. If you're
Right.
sick, stay home. Okay,
Hmm.
because we know most people who get sick from symptomatic people, not anything else. So
Yeah.
that's number one. Two, we actually screen them. Are they sick? Do they have a cough? Do they have fever? We make sure we help them recognize whether they have something or not. And when
Yeah.
they come, obviously a mask is put on, their temperature's taken before they even come in the door. And
Yeah.
we, again, do another thing. Now, in the ideal world, you'll have point of care testing for COVID sometime in the next number of months that's accurate, and we've tried to get that as ourselves, and as the OAG has talked to people about getting some of the stuff. I'm not sure how practical. Many of the hospitals have said when you're coming in for endoscopy, you have to have a negative COVID test within 72 hours of coming in. Again, I'm not sure how practical. You had a negative COVID. Did you go into isolation after?
Hmm.
There's so much lack of control over that I think you got to just keep people separate. We're using PPE. We're keeping people separate. The chances of that are very small. And I think as we have to get on with life in medicine, we can't. We may be able to keep the economy shut down. I don't think we can, but you can't keep medicine shut down forever. People do get sick, and they need to be taken care of.
Right. Now, again, in the private clinics, they are a business. And so there's additional costs associated with this. There's less revenue generating patients. And there's also a lot of cleaning and sanitization that's going on as well between cases, right? That is an additional impact on the workflow.
For sure, you have to space. You have to clean everything different. You should be, I don't know if you're cleaning it differently, but you have to make sure you're cleaning it.
Yeah.
Before, you had more people around, but we're having less people around. We're having less flow. It's going to be really hard to get the same volume of patients in. And in a business that the economies of scale the benefits come from volume. That's
Yeah.
the only variable which you can improve your bottom line from. It gets very challenging when you're limiting the volume. You really
Okay.
can't you can't do that.
Yeah.
You're paying your cleaning staff, you're paying your nurses, you're paying your admin staff all the same. So whether you do 14 cases, 12 cases, or 18 cases, so you do 18 cases, clearly it makes the bottom line better, for
Yeah.
sure.
Yeah. So I want to go back to the role of, private clinics. You touched on a little earlier, the role of the clinic in the healthcare system, and how the government perceives it as an integral part of the system. Just like long-term care should be, and other aspects. What is missing there? What is missing with the realization that in a public healthcare system like ours, there's also an important role to play with the private entities.
So, first of all, there needs to be acknowledgement of it by the government. Really, there's just passive acknowledge. They don't even acknowledge that they're there. They just say, "Someone make sure they do it properly," but that's all we want to know from them.
Yeah.
If you look at, I don't know what CCO is anymore, but Ontario Health and the CCO group of it, they've been lukewarm to being involved with the clinics or not. But in the end, they've not pushed to get them funded. When the FIT program came, they talked about doing them there, but they weren't going to pay the clinic. So how could you ask people to do the most complicated procedures and not pay them for it?
Right.
So there's just been this lack of willingness to pay clinics technical dollars. It's not anything more. But without the large volume of procedures being done in clinics, I don't know where we would be from an endoscopy delivery point of view. We wouldn't. And the number of people who have had cancers would have been higher. There's just no way that those polyps that we're taking out in the clinic, and I'm not talking about the 5 millimeter polyps, but all the other ones we're taking out aren't making a big benefit to the system and changing the incidence of colon cancer down the road. Whether we can say that there's actual trial evidence, because there's not yet, there won't be trial evidence about colonoscopy in a long time. There's no way that taking out all the polyps that have been taken out in the clinics that would not have gotten done in any timely manner in the hospital hasn't made a huge difference. CCO has this whole thing about FIT, that it's, we can't deal with all the colonoscopy, so we want to do FIT. They don't really acknowledge the limitations of FIT, which there are significant ones, of the benefits of colonoscopy in terms of polyp removal and prevention. And frankly, no one has taken into account the actual mammoth bureaucracy that takes to develop and run that FIT program. They don't ever attribute that dollar amount, which is very large, into the cost of running the FIT program. Because if you even took part of that program, colonoscopy would be a much more cost-effective delivery mechanism than the FIT program. Someone may say, well, you need that bureaucracy for colonoscopy, but you don't, because OHIP and ISIS has all the data. They get all the information from colonoscopy directly because that comes from OHIP. And so you don't need this whole bureaucracy to run all the stats that you would ever want from colonoscopy and polyp detection. In our clinics, I know my adenoma detection rate. I can't get it from a hospital. CCO can't get my adenoma detection rate. But in all the good clinics who all do quality assessments that we do, we know way better data and quality than anybody else out there. So really, there's no sacrifice in quality ever. In fact, it's probably the place I get my scope at before the hospital, actually.
Yeah. And so when you, for those that aren't familiar with FIT, could you explain a little about it and why it and the impact it will have, on colonoscopy?
Well, we so far we haven't seen, but the program for FIT, which is a stool immunohistochemical test, looking for blood. It's a single sample. It's way better than the FOBT stools that were done before. Right. The problem is picking the cutoff. There's when it's positive and negative, you can pick the sensitivity and specificity of the test based on your cutoff levels. No one ever publishes what the Ontario cutoff levels are. They won't publish them. Every time someone won't publish something, it always raises a question about why. What's the reason for not telling people what you're doing? Transparency, as we've seen in COVID, transparency really helps everybody be comfortable and understand. And when there's a lack of transparency, you always wonder why that is.
Right.
Okay. So that's the program. And, it's a mail program. You mail it back, you take it back to the lab, you mail it back to the lab. They tell you you're positive, you're negative. There's probably there's been about a 50% false positive rate in the ones I've done. And we don't know what the false negative rate is. So how many polyps we're missing. We know they don't pick up any of these serrated adenomas, which are, in fact, the polyps we're most concerned about. And so while FIT program is a better program than FOBT, it is something that can be sent out to the masses because it's just a stool test. It has its significant limitations. And I listen, if you won't do a colonoscopy for whatever your reason is, it's way better than not doing anything at all. But I still think we've missed the boat in not having a comprehensive colon screening program that involves FIT, colonoscopy, and whatever else, sigmoid, whatever else we want to throw at it. I think a comprehensive model that allows people to choose the mechanism that's best for them is probably the best system. And we've chosen not to do that as a province.
And is that because of the cost? The cost of the system, the bureaucracy, as you said, that is involved in running that, and also the fact that you're going to uncover more polyps that require an endoscopy treatment.
So it's hard to know exactly the motive. They say it's cost,
Mm-hmm.
but it's not cost when you include the cost of the bureaucracy. It can't be. It's a
Right.
more expensive model. Um, some will say it's availability of colonoscopy. Well, we have clinics that all could do way more than they do now, but because of the cost, the modeling, and the business case, they don't do more than they are. It's just it's very challenging. So we could easily up, um, our colonoscopy volumes through the clinics if we wanted. And I guess there is this thing out there um, about doctors making too much money. And the way we get paid, and we get paid by taking our polyps and doing procedures, if you do more, if you look after more patients, you make more money. That's a bad thing. Doesn't
Mm-hmm.
matter that you're caring for more patients, it's you're making more money. Everybody forgets that, you're getting paid the same thing to look after everybody.
Yeah.
If you happen to work harder and do more, you make more. But that just seems to be a concept that in this system that we have is not really accepted, and we're not allowed to charge people privately or do stuff outside OHIP, so you're just stuck. And so this notion of a private system where I'm the business owner losing money doesn't matter. I'm in a private system, which sometimes people are bothered by having accessibility. They'd be more bothered if they couldn't get into the doctor, but they're also bothered by, someone having accessibility that may be outside the system.
Right. Now, funny enough, you mentioned it earlier today on the podcast. You were involved as the endoscopy lead for Cancer Care Ontario in the creation of the QBP. Could you talk a little about QBP? Like, what was the intention of it, and did it not live up to what the expectations were, or has it exactly lived up to what the goal was?
So, I hate sometimes admitting that I was sort of myself and one other person, and I won't throw that person under the bus. I'll just take that for being the parents of QBP for the most part. But when we did it.
So what is QBP for those that don't know?
The QBP, it's quality-based funding. So you're paid a certain amount for procedures, a certain amount of procedures that are agreed to for the province. So now there's a defined envelope for payment for colonoscopy for the province.
Yeah.
So we're spending X for colonoscopy in the province, and that can be adjusted up or down. And depending on the volumes and the area, you can fund different parts of the province basically according to their population and their needs, and make it a transparent way of funding colonoscopy. The reason why we did it was very solid reason behind it. So colonoscopy was being pushed aside in many large institutions, many large academic institutions, because it wasn't in their key programs, wasn't in their priority program list. And so some of our largest institutions in Toronto, academic institutions, were losing their colonoscopy volumes because it wasn't in their core grouping of services. Well, so people didn't know where they were going to actually work. So we thought we had to find a way to protect colonoscopy. So because of those reasons, we looked at finding how much does it cost, making an average cost, because some people said it costs $300 to do a colonoscopy. Someone said it costs $150 to do a colonoscopy. There had to be a legitimate amount that it actually did cost. So we figured out what the costs were across the province. It was time-taking work from lots of things, and we actually figured out what it should cost and what it does cost. And that was the first part. Then we agreed if we took colonoscopy out of a hospital's globe and put it in its separate envelope, then whatever that number was, they couldn't make it lower. They actually had to do that volume. So the biggest incentive at the time for doing it was to protect many of our academic institutions from having their colonoscopy volumes decimated, because transplant wanted more, or cancer wanted more, or this wanted more. And,
Okay.
there was always limit on how much the government would give you every year. So that was the motivation for doing it. But, like everything, when you stick everything in a box and then someone's got a vice on the box and keeps squeezing the box, it gets harder to expand, do more. In fact, you often get numbers reduced over time. So what we did is we protected endoscopy, but we've also limited the growth in endoscopy into this little box that we're in. The clinics don't live in that box because that box all relates to hospitals, right?
Right.
So what we do is over and above what's in the hospital box, which is good. It is an outlet, but it's at an outlet where the costs are borne by the clinics. And as everybody squeezes the OHIP dollars, so our consults have gotten lower compared to everybody else. The endoscopy, the colonoscopy fees have been lowered over the last 5 years on multiple occasions. There's constant threat about polyps and what to do. So there's this constant threat about the income stream outside the hospital that affects you, where you have to pay for the expenses of it. And in the hospitals, there's not really been a growth. When FIT came, they restructured it. They pay a lot of money for the very large polyps. They don't want to pay anything for the small polyps. They just keep playing around with it just because there's a defined box that really hasn't gone up. So that's the downside to QBP. And I've asked many of my colleagues who know how it was created whether they think it was a good or a bad thing. And depending on your perspective, probably most people still think it's a good thing, but the good is not as good as it was. Let's leave it at that.
Is there a better model? Is there a model that is being used in other public healthcare systems elsewhere in the world that might be more suitable?
Well, there's many other models. Probably this is as good a model within a public healthcare system probably as you can.
Okay.
You still have to agree that if there's population growth, as there's costs, as Pentax raises the cost of whatever they're doing, or Olympus, or anybody, or accessory companies, or it all goes up over time. Although some things we get better at squeezing at, but the fact is, over time, everybody's pays more for salaries, pays more for every part of the thing. So costs do go up, but we don't have a way for the cost of our income to go up. That's not afforded to us. So that is a problem. But when you look out around the world, Canada's healthcare system is pretty unique. Nobody wants United States, but there's many other healthcare systems. In fact, most healthcare systems, whether it's Australia, whether it's the UK, whether it's Scandinavia, whether it's Europe, that all have different systems with a relief valve into some kind of private system, but still providing care for the population. There's not 40 million people without health care. Everybody gets looked after, but there are other ways to manage care and keep people getting care, taking pressure off the public system. There's so much to be said for that. But, most of the healthcare policy people around that we have to deal with aren't really of that mind.
Now, you've also throughout your career been a very big proponent of ensuring that there's quality in endoscopy, and in fact using reporting measures and reporting tools to help ensure quality is done. And so from a payer standpoint, they're getting good outcomes for the money they're spending. Could you talk a little about why that is so important in our healthcare system?
We have a public healthcare system that frankly you and I pay for. And we pay taxes. That's where it comes from. If you don't want your dollar, you don't want to pay more tax. I don't want to pay more tax.
Right.
We believe a lot of it's wasted, but not all of it. And if we had to pay more, we want to know that if they pay more, we want to know how it's being used. So The only way to know that it's being used appropriately is to use quality metrics, to make sure that if you're showing up for something, that someone's doing it right the first time, keeping track of what they're doing. And so to do that, quality is sort of the foundation of everything that we do in medicine. So, if I'm providing quality medicine and it costs a little more because that's what it costs, well, we got to find a way to figure that one out. Okay.
Right.
If we're providing crappy medicine and then we have to redo the same colonoscopy 3 weeks later, people are missing, someone shows up with cancer 2 years later because someone did a lousy job.
Right.
We're not doing the system a favor. We're not doing the taxpayers, and for sure, we're not helping the patients. Right. And so that's what it really is about. It's about proper patient care and being accountable and transparent and appropriate. And the only way to do that through quality. And so you can do quality metrics, adenoma detection rates and polyp detection rates, and cecal intubation rates and prep quality, which we all should be doing, and I think most of us are. There's ways of enhancing endoscopy in terms of skills, and that's why I got involved with CAG. That all started. I was the provincial lead for endoscopy, and we were talking about quality, and we're saying, well, what are we going to do with the ones that are bad apples? So we said, well, we're going to send them to that program, right? That seed program, which was just being started. It was pretty much in its infancy when I, in 2014, when I said, okay, that's what we're going to do. And so I said, but before we send anybody as the lead, I better go see what this is actually about. So I went and took the program, and it was revolutionary for me. It completely changed the way I approach endoscopy and I scope.
Yeah.
It's been an uphill battle. You're fighting with anesthetists, you're fighting with nurses until they understand the reason for it's a different way of doing endoscopy. But now, we're not only have I been doing it, I did 7-8 courses to get trained as faculty. I've done the polyp courses, but we actually installed the appropriate software and cameras to do the program at our clinic. So we're the only clinic that actually does it, because I think it's really important. We ran one program and COVID came. So we have not had an opportunity to run our second one. It was canceled. And as of the 2021 program, nobody knows what's happening yet. So it's not the courses haven't been published. And along the way, we had the OAG, help fund the endoscopy program for all the members who wanted to take it, because we thought it was so important that we would pay for our membership to go take the course, because that's how important we thought it was. We carved out some educational support dollars for people.
Right. So you use the course, the C course, to improve the skills of the physicians, and then you're also, of course, tracking some quality metrics, like you said, cecal intubation rate, adenomas. So how does the reporting side of it support quality care?
So, there's two parts to the reporting thing. First of all, there's a provincial report. Everybody gets a report card, but that's very limited. It has to do with cecal intubation rate, talks about your prep, because some people will put in prep quality data, and some polyp detection rate. That's all they have. And not everybody push it. It's only from the hospitals. It's not from most of the clinics. So it's incomplete data. They also know numbers of colonoscopies, and they'll put out how many colonoscopies you do a year, and if you're doing under 200, you're not supposed to do it, or you need to go get trained or whatever. So there's that provincial report card for everybody. It's limited. Then the majority of clinics are doing additional stuff with the labs, because whether you use Dynacare or Life Labs, they've all helped with the clinics to feedback the adenoma detection rate, which is a much better marker of quality than just the polyp detection rate.
Right.
And so people are monitoring, and we feed back to our group every 6 months. Everybody gets to see their polyp or adenoma detection rate against their peers and against the clinic outcome. And we feed back all the quality data we collect back to the endoscopist. So if there's any issue, we notice it and we help people remediate and look at it. We encourage people to, whatever it is, do they need glasses? Do they need, their eyesight changing? Some very fun things that come out. And often the only hint is that you see some changes in people's quality metrics where if you didn't collect them, you wouldn't appreciate them.
Right. Right.
Like the only way to know that is to collect the data and look at it. And you're not looking at it from a punitive point of view, you're looking at it from an enhancement point of view. So what can we do to help you enhance your skill, your fall detection rate, what you're doing?
And so, have you seen it evolve over the years? I mean, it must have been interesting those first few times that there was discussion about giving everybody in a unit a report card. Did that was it a kind of an evolution from, or is it still an evolution of people being willing to accept that kind of feedback?
I think people are. It's hard to remember back because we've been doing it really since the beginning. We had people come audit our thing. We published a few papers on quality metrics in our clinic, but I think people are now used to receiving report cards and understand that reporting and being accountable is just part of what we do, and it's geared to make you better, not to punish you. It's not about penalizing people. It's about identifying things where there's room for improvement. And
Right.
that should be the goal in every sector that we talk about. It's not just a healthcare sector.
Sure.
We should be improving ourselves all the time.
Yeah.
And as long as that's your goal, then feedback's only good for you to help you improve over time.
Yeah. Now you, in your clinic, have invested in a electronic reporting system to collect this data and also analyze it and provide the feedback. It seems over the last few years, electronic data collection and reporting seems to have lost some momentum, certainly in Ontario. Apparently it's going to be mandatory in Quebec to support a new screening program there. But what do you think is driving that in Ontario?
I think really it's only cost.
Okay.
I think it's a fundamental thing. Listen, I can dictate. I don't know how anybody understands what I dictate, but I can dictate faster than I can do my report on the EMR. Okay, for sure. No, hands down, I dictate faster. But someone has to then extract that data. It takes time. You need people to do all that for you. Versus doing it on a computer where you just extract the data by running a little inquiry. You can do that in a second. So there's no reason not to. We do have some good software out there, not just one, and it does all the things that you need. There's a big cost associated to implement them. And the other thing is every institution for hospital has a different EMR. So this is not part of the primary EMR in any institution. Most of them are add-ons and have to be integrated. Even if you're an Epic customer, the Epic offering is not really good for endoscopy. Right. So there's lots of issues around it, and it's cost. Then it's people learning a new thing. People still often aren't fast to adopt some new technology because there's a steep learning curve. Once you it doesn't take long, but there's this thing, it's going to take me longer. It's going to slow me down. Right. It's going to do all these things. And it will for the first few weeks, the first month. But in the longer term, it's way faster, way better, way simpler. Nobody has to read writing. Nobody has to listen to people mumble into a speaker. You can use voice dictation if you want to fill it out. It's pretty easy to do. But I think the inertia is purely cost. When we look at, from an institutional point of view, whether it's at a local level, like at a clinic or at a hospital, it's not insignificant, the cost, when people are always worried about the cost in healthcare.
But it does seem kind of bizarre in a digital world that we still have so much dictation, vast majority of the Canadian marketplace, printing paper reports, attaching photos to paper, which you then have to go back and audit manually. It seems kind of odd that this still exists in such a digital world.
I don't disagree with you, but I'm also receiving my consults by fax. So if I don't need to say anything else.
So that says it all. That says it all.
Okay. So nowhere else in the world is people using pagers and faxes still, except in healthcare. Okay. Or unless you're a drug dealer. I don't know, but that's about it. Okay.
Well, I don't. My kids don't know what a page and a fax is.
Right. So we're using pagers and faxes still, and so that in itself, and it's purely a cost perspective.
Right.
the government, there's that whole scandal about e-health and the amount of money spent for nothing and for very little output. But if you look at the government, at the Ontario Lab network that's attached to all our EMRs called OLIS now, it's the best thing. Like you had blood work done anywhere, I just pull it up. I don't have to repeat it. I get to find it. I actually get to know something at my half the people don't even send me information when I'm doing a consult. It's just there now. It's revolutionary. It just shows you how revolutionary appropriate IT integration is. Like we have the examples all at our fingertips, and there should be no reason why we don't all go there. And the only reason we don't go there is cost, and we have to figure out how we're going to do that, because it really is. If you want to provide quality care, this is just another tool to help you provide quality care. There's just no way around that.
Yeah. Well, I think that's a great place to end the conversation today. Where can people find the statement that was created on reopening clinics?
So I'm sure it's on the OAG website, and I'm not sure if the Ontario Associate Clinical Endoscopist has a website, but they have it too, and any member can reach out to them and get it from either organization.
Fantastic. Well, thanks so much for joining us on the podcast today. Really appreciate your time. It was a lot of fun.
Thanks a lot.
Okay. Have a great day. Bye now.
Okay. Bye.